Just remembering the different routes of administration to go over those. So transdermal we've spoken about. Rectal drugs we don't use. Prolidone suppositories and that we don't use that anymore. So that's probably, part of history really. Sublingual preparations we do see, with the fentanyl, and perhaps if, we get new preparations of fentanyl, we might see more there. Subcutaneous is the main route that we use. So if someone can't tolerate oral stuff, we use syringe drivers, and we have a very low, for the inpatients, we have a very low threshold of converting someone from oral or patches to a syringe driver. And why? Because it just seems to work better. Spinal, we see very little of spinal analgesia. I can't remember in the last 12 months or longer that we've had anyone with spinal analgesia in the unit. And the last patient that we actually consulted the anaesthetist on, that I just spoke about before, we actually offered this lady to go down to the Royal to have either a spinal done or perhaps some sort of block, nerve root block, and she actually declined. She didn't want to do it, even though her pain was difficult to control. And then intracerebroventricular, we haven't had a Ommaya reservoir for probably, I'd say, 4 years. So where they actually put a burr hole, then put an Ommaya reservoir, and then directly inject the opioid. Transdermal medication. Fentanyl's the only potent analgesics, really. I mean, there is buprenorphine, but it's certainly not as potent. Disadvantage is slow onset, and as I said, if you've got a difficult pain problem, you wouldn't be using it. Slow offset is not a major problem usually. Medication, another route. Rectal medication. Prolidone suppositories, we don't use anymore. The other thing that has been used in the past, and once again I've never done this, is to use MS-Contin rectally. We've got too many choices nowadays to do that, but that's something that has been used by colleagues in the past, not recommended by manufacturers. Simple analgesics and NSAIDs are still available, but once again, we just don't tend to use the rectal route. Even rectal Valium for people who are having seizures. If someone's actually having an active seizure, have you seen the rectal tubes with Valium? So it's like a little enema, mini enema. So we've still got them in the wards. But trying to track down someone's bottom while they're moving around having a seizure is not all that easy to do. Sublingual, we've talked about the Actic lozenges. They're not actually available in the public health system, but they are available through the PBS. The thing about that, as I mentioned before, you've got to actually actively do it. It's not so if you have someone who's elderly or confused or cognitively impaired in some way, it's not the drug for them. Benzodiazepines, such as lorazepam, so they can be given sublingually. The Ativan, I'm sure you've probably all used those, and clonazepam drops given sublingually. And we tend to use clonazepam a fair bit if someone's having difficulty with the oral route and they've had a history of seizures or something like that. The neurologists don't think very much of that practice, but we rarely have problems, quite frankly. And I can't recall the last patient that we'd say who had a history of seizures who we put on clonazepam who actually had more problems with seizures. I can't recall off the top of my head. So it's obviously doing something. And you've got the choice in midazolam as well, haven't we? So, but then, you need to be giving that through a syringe driver, whereas clonazepam, you can just put the clonazepam drops under the tongue, or you can give clonazepam subcutaneously as well, I guess, and it's got a long half-life, so you can get away maybe with just giving 1 dose a day. Spinal route, as I talked about, used infrequently in the palliative care setting. If we're going to do it, we sort of basically hand over pain control to the anaesthetists, really, because they like to look after their spinal route. So sometimes a temporary epidural may be useful. There are the fully implantable spinal systems. We don't use those in the public system because the public hospitals can't afford them. But if you're in private, that's another option for you. And the subcutaneous route, and that's basically what we use. So if someone can't tolerate things orally, then we'd use a subcut route. And we have a number of patients. We've had many patients over the years at home who've had pumps in, sometimes for months and months. So, and Jan's going to talk about the practical things there. So just to remember, most drugs, but not all, are well tolerated subcutaneously. But the important thing is that if someone does have a subcut site in, it needs to be looked at and monitored. Occasionally we do run into problems with subcutaneous infections, and if someone gets an infection like that, it can be, once they get, say, a staph or a strep there, then they'll get multiple sites until it's very strict about it. And sometimes it means actually taking someone off a pump for a period of time. So that can be a struggle. So potential problems, local reactions. So you just need to keep a watch on it. Sometimes you will see local reactions to morphine. You might see morphine tartrate, which once again we don't tend to use morphine tartrate anymore. We use hydromorphone. Infections I've mentioned, multiple abscesses I mentioned. Bleeding is very, very unusual. We've had patients with platelet levels less than 10. They don't seem to have major issues with bleeding from their subcut sites. And if you can, avoid sites that are edematous. We had a patient last week who had edema everywhere, like edema up to there. So that was difficult. Hypodermoclosis, giving subcut fluids. So if you need to give larger volumes of fluid, then that's certainly possible. And getting in a litre of normal saline a day is not usually a problem. That will just sort of flow in subcutaneously without any hassle. The normal site that's used is the inner thigh. If you have trouble, then you can use hyaluronidase, and I must say I haven't used hyaluronidase probably for about 3 years. So you put some hyaluronidase in the solution, and that helps with the subcut infusions. And just remember why we use hypodermoclosis. A lot of patients complain about a dry mouth. But giving them lots of fluids is not going to make their dry mouth better. It's like, the patient who's on tricyclic antidepressants, gets a dry mouth, side effect of the drug. So you could give them an extra 3 litres a day. It wouldn't really help their dry mouth all that much. So they're not actually thirsty. And I always describe to patients, dry mouth is when you're sort of getting up and you're talking for a while and you get a dry mouth. Thirst is where you're going out and you're mowing the lawn in the middle of summer for 2 or 3 hours and you actually feel thirsty. So when you get a bottle of cold cordial or liquid, you sort of drink and drink and drink and drink because you're actually really thirsty. It's not just that you've got a dry mouth. One sip and your dry mouth is better. A litre and you're still feeling thirsty. You want more fluids in. That's actual thirst. So there is a difference. There's a big difference.